Hello everybody and welcome to this Eurodrug webinar about our novel oral corticosteroid therapy, Deflacortin. My name is Matthijs de Kleer, Medical Marketing Manager of Eurodrug Netherlands, and with us are also representatives from the Georgian Eurodrug office and Professor Adcock, our speaker of today. Before I shortly introduce our speaker, I would like to notice that if you have any questions regarding the webinar or the use of Deflacortin, please feel free to contact us at info@eurodrug.nl. Professor Adcock is Professor of Respiratory Cell and Molecular Biology and Head of the Molecular Cell Biology Group at the National Heart and Lung Institute, Imperial College London. Professor Adcock obtained a degree in Biochemistry and Physiology from the University of London and later a PhD in Pharmacology from St Thomas's Hospital, London, on the role of nuclear receptors on sexual dimorphic patterns in the rat. He joined Professor Peter Barnes at the National Heart and Lung Institute in the 1990s to undertake research on the effects of corticosteroids on inflammatory mediators in asthma and COPD. This remains his major research area. Although Professor Adcock's main focus point is corticosteroid treatment in respiratory diseases, he is also well aware about the effects of corticosteroid treatment in general, and he will therefore enlighten us today on this topic regarding the treatment with Deflacortin. Professor Adcock, the floor is yours.
General aspects of glucocorticoid pharmacology and biology, and then focus for most of the presentation on Deflazacort specifically. But when we think that the first evidence that glucocorticoids were highly effective in chronic inflammation was on September the 21st in 1948, when Philip Hench gave a woman with very severe rheumatoid arthritis a cortisol extract from the adrenal gland, which had dramatic effects upon her clinical state. She was able to get off her bed and walk, but also, as we can see here from this picture, there were a number of patients treated with this that had huge effects on clinical readouts, such as sedimentation, leukocytes sedimentation rate, which is a good marker for disease activity. The Nobel Prize was awarded in November 1950, so very quick from the first into man and the award of the Nobel Prize. And quite rightly, during the award ceremony, it was debated whether or not cortisone would have a critical effect on rheumatoid arthritis and other chronic inflammatory diseases. But it was very clear very early on that glucocorticoids were highly effective anti-inflammatory agents across a whole range of chronic inflammatory diseases. And as a result, people started to overdose on the oral corticosteroids. What became very clear over the next 20 or 30 years was that the individual susceptibility to oral corticosteroid side effects was as heterogeneous as the therapeutic response in an individual patient. And there was a number of different side effects that were seen, particularly metabolic syndrome, weight gain, which was associated with high oral corticosteroid exposure, Cushing's syndrome and adrenal insufficiency, osteoporosis and bone mineral density loss. There are ocular effects, so cataracts were a well-known side effect. Cardiovascular side effects were also evident, but whether this was a direct or indirect effect due to the metabolic aspects of overdosing on or high-dose steroids was unclear. And in particular for respiratory disease, we see an increased risk of infection such that now pneumococcal vaccines are recommended for asthmatics who are on very high-dose regular oral corticosteroids. And this impacted upon the patient quality of life, and there was a long-term fear that this may induce a vicious cycle related to poor adherence and poor control of their disease. So it became really important that we understand why we're getting side effects and how do we overcome these side effects. And that's really been a long-term goal of pharmacology, the pharmacology of glucocorticosteroids in chronic inflammatory disease. In the early 1990s, we recognized that most chronic inflammatory diseases were driven by a protein called nuclear factor kappa B, or NF-kappa B, and it was activated by a whole range of different inflammatory stimuli, ranging from inflammatory cytokines, bacterial or viral infection, oxidative stress, or other cytokines. And this induced, in turn, more cytokines and chemokines, more inflammatory enzymes, and the receptors for many of these cytokines and chemokines. So we had a feed-forward mechanisms where inflammatory and immune stimuli induce further inflammatory and immune mediators, their receptors, and enhance the inflammatory response. And we can see this, and I'm just showing some data from asthma because that's where I've worked on. In patients with asthma, NF-kappa B is activated, and this is even more extreme in patients who die from status asthmaticus. So we think that this is a very important target. We and several other groups at the same time as NF-kappa B was defined, recognized that the glucocorticoid receptor targeted preferentially NF-kappa B. The glucocorticoid receptor has a classic nuclear receptor structure. So it has a ligand binding domain where the receptor ligand binds. This causes a structural change in the receptor. It's released from the cytosol and goes into the nucleus where it can bind DNA due to a DNA binding domain. And once it's bound to DNA as a dimer, then you get activation, so you get this activation domain released. And we can see this by immunohistochemistry, seeing nuclear translocation into the in the cell, or we can use tagged ligands to show in this time-lapse video microscopy that there's very rapid translocation of the ligand into the nucleus. So we can see that the ability to switch off inflammation depends upon targeting NF-kappa B, and the degree of suppression we see depends upon the dose of steroid we give. And we can see this here in a cell model that dexamethasone as a standard steroid can switch off the anti-inflammatory effects. And we can use fairly sophisticated biochemistry experiments where we tag the glucocorticoid receptor and NF-kappa B and show that the anti-inflammatory effect is due to an physical association between GR and NF-kappa B. So this is important to recognize that this inflammatory mechanism is targeted by the glucocorticoid receptor and is present through every single chronic inflammatory disease. The next major breakthrough really understanding steroid pharmacology was when the GlaxoSmithKline group in 2005 managed to get the crystal structure of the glucocorticoid receptor binding to a ligand. And here you can see the steroid ligand, the classic steroid backbone, which is embedded within the ligand binding domain, which it forms a cleft or a groove on the outside of the receptor. And you'll see this dark space here, which is actually a hole at the floor of that ligand binding domain. The ability to switch to target NF-kappa B and switch off inflammation is due to how much of one of the side chains on the carbon-17 fills this pore at the bottom of the ligand binding domain. So we can see that changing the side chains can have a huge effect on the ability to suppress inflammation. And we also, side chains interfered with how the receptor was activated. And so we can see that the duration of action, lipophilicity, and general pharmacology could be altered by changing side chains. If we look at the structure of the currently used systemic glucocorticoids, they're all based on the natural steroid cortisol, with differences in the side chains that have been introduced before we understood the molecular mechanism of how they worked, in order to improve either the potency or the duration of action. And we can see with Deflazacort that, which is an oxalone derivative of prednisolone, again, this is really a side chain that was added to change the pharmacological properties of the basic core backbone. Deflazacort is a prodrug. It's rapidly converted in the plasma to 21-desacetyl deflazacort, and this is has a much greater binding potential to the glucocorticoid receptor than drugs such as prednisolone or prednisone. And it's evident that now these modifications that were introduced before we understood the biology affect the pharmacokinetics, the receptor affinity, and how well they bind to different nuclear receptors, such as the glucocorticoid receptor or the mineralocorticoid receptor, and the efficacy and side effect profiles of commonly used systemic glucocorticoids. So, as I said, we know that the glucocorticoid receptor can bind to DNA within the nucleus, where it induces anti-inflammatory proteins, and also we think is involved in many of the side effect of steroids that we see. Whereas there's a separate effect which targets the inhibition of NF-kappa B to decrease inflammatory cytokines and other mediators. And this drove the search for different ligands of the glucocorticoid receptor that had a good anti-inflammatory effect, which we can see here. And this is a study from the GSK group, where modification of many aspects of the side chains could keep a good anti-inflammatory effect, but reduce the ability to induce a gene induction effect. And you can see this here. This is a GR reporter gene, and there's very little effect with this particular drug that has the same anti-inflammatory effect as dexamethasone. And this worked both in cell lines and in animal models of disease. So here we can see that this drug was as effective as fluticasone in a topical ear swelling model. So this shows that changing the side chains of ligands for the glucocorticoid receptor can make a huge difference in the anti-inflammatory and the side effect profile of the various ligands. And it provides scope for improvement of the therapeutic index for steroids. However, no drug has actually come onto the market that has been developed using our knowledge of dissociated pharmacology. But we do know from those structural molecules I showed you that we have got drugs that do have these modified side chains. And one of these is Deflazacort, which was initially developed in 1985 and has been approved for Duchenne's muscular dystrophy in 2017 by the FDA. And I'm going to tell you now something about the biology and the pharmacology of Deflazacort that may give us hints as to why this drug, without being developed specifically, has many of the features that we and other companies such as Glaxo have spent a long time trying to develop on the back of understanding glucocorticoid biology. And I hope to show you that Deflazacort has an improved therapeutic index for steroids and is suitable for dosing as an oral compound. So Deflazacort acts as all steroids do through activation of the glucocorticoid receptor. It's very efficient at targeting granulocytes such as neutrophils and eosinophils. It can target monocytes and macrophages, preventing their recruitment and activation. It's also very effective at suppressing dendritic cell function and the subsequent activation of a whole range of different T cell subtypes, depending upon the model in which it's been tested. Deflazacort is also effective against structural cells in various tissues, such as epithelial cells, endothelial cells, for example. So it has all the characteristics that we'd hope of an anti-inflammatory drug. And in a number of different clinical trials involving over 150 patients, we know that the ratio of potency for Deflazacort against prednisolone is about 1.2 to 1, although this range up to about 1.5 to 1, depending on the disease and the individual patient. And we generally consider that Deflazacort as a dose of 6 micrograms has very similar anti-inflammatory potencies as prednisolone at 5 mg. So what are the characteristics of Deflazacort? It's incredibly well absorbed after oral administration and is rapidly converted to the active metabolite 21 desacetyl Deflazacort by esterases within the plasma. Peak plasma concentrations are reached within 1.5 to 2 hours, and it has a very short plasma half-life compared to many of the other steroids such as prednisolone or prednisone. Importantly, only 40% of Deflazacort is protein bound, and this is secreted mainly via the kidneys. And this compares with prednisolone, which has 77% protein binding, and for pharmacological purposes, it's only the free non-protein bound drug that actually has an anti-inflammatory effect. Desacetyl Deflazacort has low lipid solubility, which means it doesn't cross into the blood, doesn't cross the blood-brain barrier, and it has a high volume of distribution, which means most of the drug goes out into the tissues where we require the drug to act, rather than stay in the plasma. And it's this combination of the high volume of distribution, the protein binding, and the affinity for the glucocorticoid receptor that gives us the extended duration of action that we see with Deflazacort compared to what you might think of, compared to that which we see with prednisolone. So we have an equal duration of action despite having a very short plasma half-life. So the pharmacology and the PK/PD ratio tells us that we have this long duration of action. We also have reduced effects on numerous aspects which are, as I described earlier, are important side effects profiles of glucocorticoids. So here, and I'm going to show data from a number of studies, patients who required oral steroid use were given either prednisolone or Deflazacort and showed clear improvement with both treatments. So there's no difference in the improvement, clinical improvement. Both steroids didn't significantly decrease trabecular bone, but the bone loss rate induced by prednisolone was significantly higher than that induced by Deflazacort. As we can see here, Deflazacort doesn't reduce the bone mineral density by anything like the extent that we see with prednisolone. We can see this in other studies, in this case in kidney transplant patients. We can see bone mineral density in the lumbar spine was much greater, reduction was much greater with prednisolone compared to Deflazacort, and the increase in body fat mass So the increase in weight, again, was much greater with prednisolone compared to Deflazacort. And this related to changes in serum lipids in the time after transplantation. Deflazacort had a much better profile than that which we saw with prednisolone. There are other aspects that were important for safety, comparing prednisolone and Deflazacort. And here the anti-diabetic effect of Deflazacort was much better in patients who were at risk of diabetes. If we look at the plasma glucose levels, the effect of prednisone was much greater, prednisone was much greater than that which we saw with Deflazacort, which suggests that Deflazacort might be more suitable than prednisolone and other similar steroids in pre-diabetic subjects. This was an early study, 1982, and it's subsequently been shown that we get much better control of blood glucose, we get reduced insulin requirement with Deflazacort compared with prednisolone and prednisone in insulin-treated diabetics. So we have a greater safety ratio. Cortisol is produced by the adrenal gland, and it feeds back upon the signals that stimulate its release from the hypothalamus and the pituitary gland, so that we get ACTH and CRH are both suppressed by endogenous cortisol, which means that if we're giving high-dose, long-term synthetic glucocorticoids, they will also suppress the HPA axis. And this is associated with significant side effects such as Cushing's syndrome. This becomes particularly acute if we have withdrawal, particularly inappropriate withdrawal of these oral corticosteroids, which may lead to adrenal insufficiency, steroid withdrawal syndrome, and reactivation of the underlying disease. What we can see in various studies that have compared the duration of ACTH suppression and adrenal suppression with various oral corticosteroids, that Deflacortin has a much milder effect than the comparator drugs prednisolone or triamcinolone, which seem to cause a much more prolonged suppression of ACTH and adrenal suppression. So there's a much greater safety window with the withdrawal status, and I can show you some data later and how we can go about the withdrawal of drug if this is necessary. So if we summarize some of the pharmacodynamics and pharmacokinetics data, the metabolic effects of Deflazacort at therapeutic doses that are equivalent to that of prednisone showed less effect on calcium absorption and bone mineral density effects. We have better metabolic control of diabetic patients and a better glucose tolerance. We have a much longer impact upon blood lymphocyte levels, which may reflect an effect on the target on the storage sites for these cells. We have a much reduced effect on the bone mineral density and volume of bone. And I haven't had time to show you, but long-term studies in children suggest that there's a much reduced effect on growth suppression in children compared with any other oral corticosteroid that have been compared, such as prednisone or prednisolone. So there's a much improved safety profile. I'm now going to give some head-to-head comparison data from clinical trials in different diseases. The details of the diseases are going to be on the slide, but I'm not going to discuss those. I'm going to talk about the comparative effects on treatment efficacy and side effect profiles. I said that at the start that Deflazacort has been licensed for Duchenne's muscular dystrophy. And we can show here from this study, which is a post-hoc analysis from a large ACT Duchenne's trial, that all of the indices related to the motor function and loss of ambulation favor Deflazacort compared to PREDNISOLONE or PREDNISONE. And this reached significance for the 6-minute walk test and the 4 stair climbs. So we can show that, demonstrate that despite a similar effect clinically, we have this improved side effect profile with Deflazacort compared to PREDNISONE. In a separate study looking at, again, Duchenne's, 12 weeks treatment with PREDNISOLONE and Deflazacort had a similar improvement in muscle strength and motor function compared to placebo, where we saw no effect. But Deflazacort was associated with a much less weight gain and fewer psychiatric adverse events than we saw with PREDNISOLONE. So here we can see the comparison. So despite equivalency in the clinical outcomes, the side effect profile was much better with Deflazacort. There have been several studies that have looked at weight gain in patients treated with PREDNISOLONE versus the Deflazacort, and all of these show that the weight gain is greater in PREDNISOLONE despite the similar efficacy in Duchenne's disease. So in conclusion, a recent meta-analysis of a number of multicenter clinical trials have shown that Deflazacort-treated patients have a lower decline in 6-minute walking test, have a greater increase in rising from sitting. They have a better 4-stair climb time, and the North Star ambulatory assessment is much greater. So compared to patients who are on PREDNISONE or PREDNISOLONE. In addition, Deflazacort-treated patients experience significantly lower functional decline over 48 weeks, showing that in Duchenne's, Deflazacort has a much better therapeutic index than we see with PREDNISONE or PREDNISOLONE. And these differences are not only seen in Duchenne's, they're also seen in other diseases. And here I'm going to show data from children with idiopathic nephrotic syndrome, where we can see that the time to remission is much less in the Deflazacort group. There are fewer relapses in Deflazacort on follow-up, and had less effect on suppressing growth than PREDNISOLONE in this study. In a similar group of patients, but in a larger study, we can show again that the number of relapses was significantly lower in the Deflazacort group compared to the PREDNISOLONE group, and the mean body weight was increased much greater in the PREDNISOLONE group compared to the Deflazacort group. The incidence of Cushing syndrome also tends to be much greater in the PREDNISOLONE group compared to the Deflazacort group, although this didn't quite reach significance after 1 year. So overall, the study seems to suggest that in idiopathic nephrotic syndrome, we have increased remission, less Cushingoid symptoms, less weight gain, and less bone reduction. And we can also see this in patients who are undergoing transplantation and could be converted from PREDNISONE to Deflazacort. There was no difference in the clinical outcomes in immunosuppressive ability of either drug as measured by graft rejection, dysfunction of the graft, or severe infection. But there were differences in the ability to control blood glucose and the need for insulin or oral blood glucose lowering agents. So Deflazacort was much better compared to prednisone in all of these factors. And it suggests that, in these patients, Deflazacort may overcome the problem of glucose intolerance without interrupting the immunosuppressive action of other oral corticosteroids. In lupus, we see that although there was no difference in the comparison between Deflazacort and prednisolone in disease activity indices, patients on prednisolone had a much greater weight gain than those on Deflazacort. They had a higher increase in the incidence of hirsutism and an increase in Cushingoid severity index scores compared to Deflazacort, suggesting again that the Deflazacort would be a much more useful drug with fewer side effects compared to prednisolone, and gave similar clinical efficacy in this in lupus patients. And finally, a study in drug-resistant childhood epilepsy, you can see that comparing patients on hydrocortisone with Deflazacort, although there was no difference in the efficacy as measured by decrease in seizure frequency, the adverse events associated with hydrocortisone were much greater and highly significant, the increase in the in hydrocortisone-treated patients compared to Deflazacort-treated patients. So again, we can see that Deflazacort is as effective as other oral corticosteroids, may be used for much longer therapy in these patients, and has a much less worrying adverse effect profile than we see with hydrocortisone versus Deflazacort. So I've had a quick run through of some selected clinical features across a number of different diseases. So in summary, what we can see is that Deflazacort has a very good anti-inflammatory profile, as good as that which we see with prednisone, prednisolone, or injected triamcinolone. And this may result from its pharmacokinetics and pharmacodynamic properties. It has a more potent stimulation of the glucocorticoid receptor than prednisolone, for example, but it has a shorter half-life in the human body with a much greater volume of distribution, and it has a greater duration of action on blood lymphocyte levels. It also has a reduced plasma protein binding capacity, which overall means that it's going to have a similar overall anti-inflammatory component. The active metabolite, 21-deacetyl Deflazacort, has a low lipophilicity and very little crosses the blood-brain barrier, which may help to account for why we see a much reduced impact on the ACTH and adreno suppression effects that we see with reduction or withdrawal of Deflazacort compared to other drugs. And overall, we can see a similar duration of the immunosuppressive or anti-inflammatory effects with Deflazacort compared to other oral corticosteroids, with the benefit of far fewer side effects compared with drugs such as prednisone or prednisolone. So The key aspects of reduced side effect profile of Deflazacort really relate to this, this impact upon the HPA axis and ACTH reduction, so we get much less withdrawal symptoms after discontinuation. We see much less impact upon the bone mineral density and bone mass, and data I didn't show you, which is on steroid-induced osteoporosis in elderly patients. We see less growth impairment and behavioral changes in children on Deflazacort compared to other oral corticosteroids, and also there's reduced incidence of steroid-induced diabetes and glucose fluctuations in pre-diabetics and diabetic patients, which I showed you some of the data for. And we also see a reduced incidence of hypokalemia in patients treated with Deflazacort and patients treated with other oral corticosteroids. So we, overall, we have an equivalent anti-inflammatory component with a much improved side effect profile with Deflazacort. So what are some of the practical implications of using Deflazacort? So if we wanted to dose your patients, I said earlier on that we think that Deflazacort at 6 mg or 1 pill is considered as effective as 5 mg of prednisolone or prednisolone. We can titrate to obtain optimal suppression if this is required, and we normally do this by increasing the dose by a quarter of a pill or 1.5 mg. You can take Deflazacort, preferably daily, in the morning, and this fits with the diurnal variation of endogenous cortisol. But it doesn't matter whether the tablet is taken on an empty stomach or after eating. Because of the pharmacology of Deflazacort, we can give very high doses for a short term, and doses of up to 90 mg per day have been given depending upon the severity of the disease and the status of the disease. If we're thinking about pediatric patients, we tend to be looking at a quarter to 1.5 mg per kilogram per day Deflazacort. Importantly, the therapeutic effect, because of the rapid conversion to the active 21-acetyl Deflazacort, is within 2 hours after administration. So on that note, I hope in this quick run through, we're able to show you some of the biology behind how steroids work and why they're effective, how we can change the side chains that are associated with many of the key aspects of the pharmacology of oral corticosteroids to change their PK/PD impact, and these changes will explain why we have such a good anti-inflammatory effect of Deflazacort with a reduced sort of side effect profile compared to other oral steroids such as prednisolone or prednisolone. So I'd like to thank you for your attention, and I'm happy to answer any questions. Thank you.
Well, thank you, Professor. Sorry, I think that your volume is a little bit turned up a little bit too high. Could you? Yes, that's better. Now I cannot hear myself twice. Let me quickly unpin you so that the other people can see me as well. Well, thank you, Professor Adcock, for your presentation. I think it was very helpful, very clear, showing the benefits of Deflazacort in the treatment in various diseases. Maybe we can stop share your screen for a moment at this stage.
Okay, yeah. Sorry, there.
Would be nice. The first thing is that, first of all, let me note for the audience that there's still time to ask a question, so please type them down below in the Q&A. We already received 2 questions from the audience, which is great. So there will be, and I also received some questions prior to the lecture. I think most of the answers were already provided. But anyway, I will still try to ask some of these questions which haven't been provided yet. So the first question was, does Deflazacort interact with other medications? I don't know whether you could answer that question.
I think that that's not my area of expertise, but I think that what I will say is that you would expect Deflazacort to have similar drug interactions as we see with all oral corticosteroids. So this will be a class effect. So there wouldn't be any differences. Now I may defer to one of your colleagues onto which particular class of drugs you wouldn't want to have, but I would say that maybe some of the I mean there may be beneficial effects, as I mentioned before, in if we were using long-term high-dose oral steroids, there might be an impact upon the risk of infection, but I think this is something that we don't see that often, but we have to be aware of. And I think this is going to be the same with any oral corticosteroid. But if necessary, I can come back with you on this.
I was just going to say, like, I have a complete list available for all drug-drug interactions which are already noticed with the Deflazacort in the past. So, which have also been provided in the clinical,
right, okay, that's good.
clinical trials already. No worries about it. I thought you're completely right in this regard. It is comparable to other glucocorticosteroids. There are some specific details, but it's mainly like, so for instance, you have to watch out for several liver breaking down enzymes. But that's similar. Like it's very similar to cortisone and to prednisone and everything. All right. The second question I received was, are there any studies comparing Deflazacort and methylprednisolone?
Sorry, with methylpred?
With methylpred, yes.
Yes, there are. And essentially, we're seeing this when we do the comparison on the equi sort of dosing, so that then we're seeing equivalence in the clinical effectiveness of the drugs, but there's also again the same improved side effect profile that we see with Deflazacort. So there are a number, and there's handouts to show you the number of studies comparing those. I didn't pick every single steroid, but yes, we do have studies which show this quite nicely.
Exactly. To be very frank, like I, of course, had the time to look it up also during your presentation. There are currently several trials available. 2 I would like to highlight, which were proposed in rheumatic arthritis patients and in children after post-renal transplantation. What you see here is, as was provided already by several of your accounts, which was that we see a much reduced side effect profile while remaining the efficacy as seen with methylpred. So this, I think, is the best.
I think we take them as a group.
Exactly. So that's been provided a couple of times already, indeed. So the questions keep popping up. There are so many. I would like to. So the next one is if you've had experience with prescribing Deflazacort in patients with croup, since it understands gives you effects in 1.5 to 2 hours?
Yeah, this is a very interesting question, and we don't have it for using croup, but I guess it is a very rapid-acting steroid. So there's an opportunity there. I mean, for us in the UK, we wouldn't because it's not licensed, but that doesn't mean that it doesn't have a profile. We've discussed lots of studies where Deflazacort isn't licensed, where it's highly effective, but it's a very good consideration because of the very rapid action compared to other steroids. It has potential, and I don't know if there's any studies. I'm not aware of any where it has been used. Do you know, Matthias?
No, there hasn't been a trial performed on croup specifically, unfortunately. But I think
that's a really good. I think that's a really good question. So it's something we should think about.
Yeah, and also another very, like this person, he had a second question, which is also very good to my experience, to my opinion. So, do you have experience with COVID patients in inflammatory storm in the Deflazacort use?
That's a really good question. So, about when and what dose you give steroids. Most of the data we have in the UK really reflects around dexamethasone. That was the standard dose, and that depends on the effectiveness of the dexamethasone depends on when you give it to the patient, the dose. So it's not giving very high doses was effective in the really severe patients. It didn't work out as we thought. So it was a moderate dose in not the extremely severe patients. I could imagine that because of the anti-inflammatory effects of Deflazacort, that if you were on Deflazacort, and were exposed to COVID, you may have a reduced I guess, severity of the disease because you're blocking the initial inflammatory drive associated with the infection, and a similar rationale may explain why we see patients who were on chronic sort of high dose topical or oral steroids. Tend to be protective. I have particular interest in respiratory disease, so we see this with asthmatics. So asthmatics actually have a reduced susceptibility to COVID than healthy subjects. So is this the steroids they're taking, or is it because they're hiding away? And from personal experience, there are some patients who are hiding, but there's certainly a lot of asthmatics who aren't hiding. So is that something that the use of steroids is actually protecting against the impact? But that, of course, is as a prophylactic rather than a therapeutic intervention. And I don't think there's been any studies on Deflazacort as a therapeutic in COVID. People have been dumping in sort of dexamethasone generally to see whether there's effect. And I don't think there will be a specific study at the moment on Deflazacort.
No, definitely. Like it is. There, fortunately, it's been too soon to dive deep for this Deflazacort.
Yeah.
So if we continue, then we have next question is there a intramuscular intravenous formulation of the drug available? I can answer that question. No, unfortunately not yet. But this is definitely something, like, it is available, but not in Georgia yet.
Yeah.
So there is an IV formulation available, but unfortunately we haven't launched it yet on the market. This could definitely be something for the future. Then could be,
yeah. So that's for you to
yeah, to continue
to the registration agencies. Yeah.
Another question was that regarding what about the use in pregnant women? Is that possible?
I would again go back exactly the same as issues we have with any oral corticosteroid. There is no major concern. We would keep patients on their, if they are on Deflazacort and they became pregnant, you wouldn't change the treatment. This is good practice. You wouldn't change this, and I don't think there's any evidence to say that there's adverse events. I'm not sure whether Matthias, if there's been anything reported, but I'm unaware of anything. That's
at this stage, I have to look that up. That's
I think this is this would be the same way we don't take any of our severe asthmatic patients off their oral corticosteroids when they become pregnant. We look after them a little bit more, but we haven't had any problems. And it's, I guess, we'd think, my own viewpoint is that the withdrawal of oral corticosteroids in people who are pregnant is probably worse than any of the stress effects that may be induced by the pregnancy. So I would think that it's much, much safer to control whatever underlying disease they have than withdrawal of steroid.
Yeah, I would agree in this regard, but let me at least, I will...
Yeah, but it is worth looking up. I mean, I think it's going to be an absence of evidence aspect. Yeah.
In the quick time you gave the answer, I had a quick look up, and indeed, what I saw in our available data is indeed that there is a lack of evidence at this stage. But for corticosteroids in general, it is it's been used, but not that frequent. So I would say if you're using it currently with your current steroids, I don't think. I will ask you as a question. Do you think there would be a difference between Deflazacort and, for instance, prednisone if you would give it to, if you would already provide it to a pregnant woman?
No, I don't think there'd be any difference. I mean, we discussed with in some of the studies that Deflazacort would be better side effect profile, but I wouldn't think that you would withdraw Deflazacort from any women who are pregnant who are taking Deflazacort or for their underlying condition. Treating the underlying condition is the most important factor.
Yeah. That I think that's definitely important. Then also another question is, this is a question which might be a little bit too specific, because why is the Deflazacort not displayed in the steroid calculator? May it need time to be reflected there. I do not know which type of steroid calculator that could be, but maybe something about the conversion rate you could mention or tell us about. You already mentioned.
I mean, there have been a number of published papers looking at what is the conversion rate, and so I think the Calves paper and certainly the paper from Luca Parente show very clearly what the conversion rate is against a whole range of different oral corticosteroids. And I think so there are conversion rates. It's whether they go onto the formularies and whether they go into the guidelines is something that takes time. And this is really forcing users and companies to talk to the people who write the guidelines. And I think it should be. The more it's used, it should become more. There's a greater need to have these conversion rates. They are available, and I can't see a reason why we're not doing this. It's an approved drug. We should be having this conversion rate freely available, rather than look up in a research article.
Definitely, but I can at least tell to the whole audience that we have a conversion ratio with the general therapies compared to the Deflazacort available in our brochure. So if you need to look up what the amount for Deflazacort should be compared to what you're now giving your patient, you can always find the conversion ratio in our available brochures and informatory documents.
But it should be on the guide. I think it should be within the guidelines, because it's used.
Definitely, and I totally agree with you in this regard. Then the last question I have for now is regarding the pediatric population.
Yep.
The question I received was, there's of course a lot of data available in Duchenne, but next to Duchenne, like it's a very specific disease, Duchenne muscular dystrophy, is there also other pediatric data available?
Yeah, there are, and I didn't really go into the pediatric aspects, but we have data in RA, we have data in a number of other diseases where we show very clearly that Deflazacort is safe. It's actually safe. It has a better less of an effect on growth rate when used in children, and this is across all studies. So I think that there is a good degree of evidence that we're seeing Deflazacort as a good drug for children. If you're going to be given a long-term therapy, giving an oral steroid to a young child, this is something that we should be considering because of the safety aspects and the limited effect we see on growth velocity in children, and this is a long-term growth velocity, and any effect we're seeing on bone density. And I think again you have all the details of the studies available in children, and there are a number of these available. And I know you're looking them up now.
Yeah, definitely. Yeah. There are several, but one aspect which I would like to highlight in this regard is, do you also know a little bit about the behavioral changes in children regarding corticosteroid therapy?
Yeah, there seems to be, and I mentioned it in one of the slides. There's fewer psychological adverse events you see with Deflazacort in children than you do with PREDNISOLONE. So I think this is actually very important, where a child has a chronic disease that requires oral corticosteroid. This is stressful enough. They'll have psychological problems from that. If you also have a problem of the drug, such as PREDNISOLONE, inducing some adverse events related to psychosis, then if you can reduce that, that becomes really important as well. So thanks for reminding me. I think this is very important. It's an issue that we see with all children on high-dose oral steroids, is these impacts on neurological behavior or psychological behavior. Yeah.
And to my opinion, I think that's a big fear of parents, like to give withholding their children to give.
And I think there's an opportunity to give them a drug that is effective and doesn't have anything like this, those effects that we see with PREDNISOLONE, for example.
Exactly. Well, thank you. Another question popped up. This is regarding, and I had the chronic rhinosinusitis with nasal polyps. Do you have experience with Deflazacort treatment in that population?
Oh, personally, no. So, yeah.
No, to be very frank, at this stage, this might be...
Yeah. Very, very, very interesting. So, whilst reading this, we around the area. So one of the things, one of my interests is in severe asthma, and some of the really severe asthmatics are the ones who have chronic rhinosinusitis with nasal polyps. Nasal polyps are a really big marker for very bad severe asthma. And this is something that's made me think about what we're doing. We've put people on prednisolone or methylpred, and we haven't really thought about Deflazacort in these patients. And that may be, again, something that we should have been thinking about. They also have a huge, a lot of problems and side effects that we should be thinking about switching drugs. So thanks for bringing that up. I think this is a really important problem. It's an underreported problem, and it's very hard to treat effectively when you need to have high dose oral steroids.
Yes. All right. Then I believe those are the questions which are currently being asked. So I think I would like to thank you again, Professor Adcock, for your time. We're on the mark, exactly 5 o'clock. And I would like to also thank all the attendees today. If you have any residual questions, or if your question wasn't answered to full completion, in your opinion, please do not hesitate to send us an email or to contact your direct one of our representatives directly. We will always try to answer within a week, and to also provide the scientific materials underlining our statements at all times. So please do not hesitate. We are here for you to help you to get to know this product better and to see also this benefit which we showed in the presentation for your patients directly. Again, thank you, Professor Adcock. And I would like to wish everyone a pleasant weekend and a pleasant evening. So with this, I will end the webinar.
Okay, I'd like to offer my thanks to everyone who listened, and also have a very pleasant weekend. And I hope it's not as COVID affected as our weekends are.
I hope so as well. All right.
Okay. Thank you very much. Bye. Okay. Bye.
Eurodrug. We research for the human needs of tomorrow.